Good afternoon, everyone, and welcome again to Dr. Lakhanpal's Venous Exchange. We appreciate you joining us this afternoon. At this time, I would like to introduce Dr. Sanjeev Lakhanpal, who will provide more details about our Venous Exchange and today's presenter and presentation.
Thanks, Jessica. Thank you very much. Thank you, guys. Thank you very much for taking the time to join us today over your noon hour. And as every time, we have another great topic for you today. This is Center for Vein Restoration's commitment to education. It's our way to show gratitude to all of you, our referring physicians, our associates, other people involved with treating venous disorders. Before I go a little bit more into introducing Center for Vein Restoration to those of you who are new to us, just certain reminders, please mute yourself. We do want this to be very, very interactive. The talk, even though the topic is a huge topic, is limited to about 30 minutes. Dr. G. Lakhanpal is going to try to just say enough to get your interest in the topic going. Please ask questions as simple as the questions might be. This is all an evolving disease treatment process. Even though the disease has been there for a long time, we're all learning more, getting better and better at how we treat venous disorders. So please try to make it as interactive as possible. You will get your CME certificate either digitally or one of our physician liaisons will drop it to you. The way we choose these topics is purely based on how you all respond to them and what are the topics you want covered. So please do reach out to me at my email address so we can include the topics that are of interest to you all. Again, a quick word, Center for Vein Restoration is now 90 plus clinics. We are all over the Northeast, into the Midwest, going into the Southwest as well. We have our presence in Alaska, Texas. All this is possible just because of here accidentally. So all this is possible just because of your trust in us, you trusting your patients, which we take very, very seriously. This is the amazing group of physicians who makes it all possible. These are the doctors who are with Center for Vein Restoration, and can't thank them enough for taking all the extra time. We have our fellowship program. We have a lot of active research going on. Just this year, we've submitted and we've been accepted for 12 abstracts. So all that is our part of giving back to the community. With that quick introduction of Center for Vein Restoration, want to first introduce the topic for today, post-thrombotic leg syndrome. It's, as you will learn from Dr. G. Lakhanpal, that it is not as rare as you might think, an extremely debilitating process, but now we can do more and more to first prevent this and then help patients who develop post-thrombotic leg syndrome. Dr. G. Lakhanpal is the medical director for Center for Vascular Medicine. Center for Vascular Medicine is our sister practice, which deals with deep venous disease and arterial disease. And with that introduction for Dr. G. Lakhanpal, I will pass this on to him. Just one more quick thing. Dr. G. Lakhanpal has done more deep venous interventions for non-thrombotic disease than pretty much, I would say, anybody else in the country. Our teacher, our mentor is Dr. Raju, who clearly has done a lot more in the entire field, but for non-thrombotic disease, I really feel Dr. GL and Dr. Satwa, our two key doctors, have a lot of experience. So with that, Dr. G. Lakhanpal, please take it.
Thank you, Dr. Lakhanpal, for the kind introduction. I'm going to share my screen here. I cannot share unless you want to share.
No, you can share. I have stopped sharing.
Okay. Can you see my slides?
No, we cannot.
Okay, let's see.
Yep, now we can.
Okay, so post-thrombotic syndrome, essentially it's a clinical diagnosis. We do take some diagnostic testing to help with that, but essentially it's based on the patient's presentation and the clinical, follow-ups that we do on these patients. So it refers to symptoms and signs of chronic venous insufficiency that develop following DVT or a deep venous thrombosis. It is a condition previously used to be thought it will happen in 100% of the patients, but we have more validated criteria now. And this tells that, which shows that about 20 to 50% of the patients, some say up to 60% of the patients will develop PTS after DVT or deep vein thrombosis. And the pathophysiology of this is a combination of reflux due to valvular incompetence and venous hypertension due to thrombotic obstruction, which causes the manifestation of symptoms to happen. Inflammation may also play a role in the development of PTS by delaying the thrombus resolution and inducing vein wall fibrosis, which in turn promotes the valvular reflux. And also the signs of the chronic skin changes and the discoloration which accompany this is explained by the increased venous pressures, which are then transmitted to the capillary beds, promoting transudation of fluids and large molecules. And this results in tissue edema, subcutaneous fibrosis, tissue hypoxia, and ulceration. So the Stop the Clot initiative was started by CDC in about 2015. The basis for that was the large number of people or large volume of people who were being affected by venous thromboembolism. Up to 900,000 can be affected. And the latest slide from that CDC website says one person can die every 6 minutes from a pulmonary embolism. So about 60,000 to 100,000 Americans die of DVT, and 10 to 30% of people will die within a month of diagnosis, and sudden death may be the first presentation in about a quarter of the people. So in order to address all of that, this Stop the Clot initiative was started, and to make the physicians and the population more aware of how to treat and prevent. And then as a subsequent manifestation of post-traumatic syndromes will get reduced once you stop the progression of the DVT. So this is an extreme case of a person who has had post-thrombotic syndrome. This is a venous ulcer you can see in the medial aspect of the ankle. And this is what we call the C6 part of the disease. The clinical manifestations otherwise of post-thrombotic syndrome include symptoms and signs such as leg pain and heaviness, edema, redness, telangiectasias, appearance of new varicose veins, hyperpigmentation, which is discoloration of the skin, thickening of the skin, and in severe cases, as this picture shows, is leg ulcers. And these symptoms will tend to get aggravated with prolonged sitting or standing or walking, because that increases the venous hypertension, and they improve with rest and leg elevation. Because when gravity gets eliminated, blood is able to get out of those thrombotic veins a little better, and that reduces the pressure inside the veins, and that causes improvement in the symptoms. So the symptoms usually occur within 3 to 6 months after diagnosis of DVT, but they can occur even as late as 2 years after the diagnosis of the initial DVT. And about 5 to 10% of the patients will develop severe post-thrombotic syndrome. And this picture is about a little less manifestation of the signs of post-thrombotic syndrome. There's discoloration on the right side. The left side is probably skin thickening, what we call C4B stage of the SEEP classification. So if you do a breakdown, edema occurs in about 2/3 of the patients with post-thrombotic syndrome, skin pigmentation about 1/3, and venous ulceration is seen in less than 5% of the patients. And because these symptoms overlap a lot with patients who have chronic venous insufficiency, so people who have primary chronic venous insufficiency will have the same manifestation of symptoms. So the recommendation is, or the expert consensus is, to wait up to 6 months following an acute DVT before making a diagnosis of post-thrombotic syndrome. And as I mentioned before, venous duplex and intravascular ultrasound, along with venography, they are the main imaging modalities for assessing the obstruction or venous reflux in patients who have post-thrombotic syndrome. The Villalta Score is an international standardized scoring system which helps us to make a diagnosis and assess the severity of post-thrombotic syndrome, and it's universally recognized. And majority of the studies that are done in patients who have post-thrombotic syndrome are based on Villalta scores. So it is based on these symptoms and signs, and the score runs from 0 being no symptoms to 3 being the severe symptoms, and the clinical signs, they're listed here again, 0 to 3. A Villalta score of less than 4 is normal, meaning no PTS. 5 to 9 is considered mild PTS, 10 to 14 moderate PTS, and greater than 15 is considered severe PTS. And if a patient has a venous ulcer, automatically puts them in the category of severe PTS. Just a little bit of the financial burden of this disease. The annualized median cost for DVT patients who develop PTS was $20,569 compared with $15,843. This is a little older statistic. It's probably gone up now. And it is estimated that 2 million workdays are lost annually in the United States due to leg ulcers. And if you start counting venous ulcers into this equation, then the cost of treatment or healthcare on the burden on the healthcare system goes up to $20 to $40 billion. By studies which have been done. Now, every patient who comes with a swollen leg, with discolored leg, may not have a post-thrombotic leg. The differential diagnosis, as I mentioned before, includes primary venous insufficiency. So a person who just has incompetent refluxing superficial veins can present with the same presentation based upon how chronic the disease has been. Increased body mass index leading to lipedema is one of the other differentials to be aware of. Lymphedema, any tumors or arterial aneurysm which can cause venous obstruction, and then this is an extrinsic compression causing reflux and obstruction to the drainage will cause swelling in the leg. Baker's cyst, especially if it's a ruptured Baker's cyst, can cause a lot of calf swelling, and that can be mistaken for PTS. And any extremity injury can cause a presentation like PTS. Now, when we go to the diagnosis and the severity, we look at risk factors. So we look at what is the predisposition of this patient to have PTS, and we base it upon patient-specific risk factors, the characteristic of the DVT, which can predispose you to have PTS, and the treatment which was done for the DVT, which in turn can cause the patient to be predisposed to PTS. So pre-existing primary venous insufficiency, older age, and a BMI of greater than 35, as well as presence of varicose veins. All these are increased risk factors for developing PTS. There is no consistent relationship between gender, so male and female patients can be predisposed equally. Thrombophilia, again, does not appear to increase the risk, and provoked versus unprovoked DVT has not been found to be an increased risk for PTS, either or. So it can happen in a patient who has provoked DVT or unprovoked DVT. And when we talk about the characteristics of the clot itself, which happen, primary versus recurrent DVT is considered a 6 times increased risk for developing PTS, especially if it's a recurrent ipsilateral DVT. So if a patient has one leg which gets recurrent DVT, whether it's in the femoral popliteal or tibial or iliofemoral, there is a 6 times likelihood that these patients can develop post-thrombotic syndrome. Symptomatic versus asymptomatic DVT, again, patients who have symptomatic DVT are higher predisposition to develop PTS compared with those who have had asymptomatic DVT. Proximal versus distal DVT, again, proximal defined as iliofemoral and femoral popliteal, will have more absolute risk of trophic skin changes, and there is a 2-fold increase of developing PTS symptoms and signs compared with patients who have had below the knee DVT. And even if you do develop PTS symptoms with distal DVT that is below the knee, those manifestations are much milder compared to the ones who have had more proximal DVT. The presence of a residual thrombus within the first 6 months after the thrombotic episode, again, appears to be a risk factor for PTS. And there's a mention of elevated D dimers in the weeks to months after DVT, which may be a modest risk factor for PTS. Now, getting to the treatment part. So if the patient has used thrombolysis, if the patient has been given thrombolysis to treat the acute proximal DVT, it may decrease the risk of post-thrombotic syndrome by reducing the clot burden and preventing proximal vein dysfunction. But there's a lot of controversy about it, but I just cited a few studies. The Kevin study, which was published in 2012 out of Norway, it was a study in which they evaluated patients who had iliofemoral DVT, and they were assigned to conventional treatment plus additional thrombolysis within 21 days of symptom onset. And at 24 months follow-up, there was an absolute risk reduction of about 14.4% in the patients who had been treated with thrombolysis, and the numbers needed to treat was 7 to get an absolute benefit. An additional 3% risk of major bleeding was noted in the patients who underwent thrombolysis compared to the one with the conventional treatment. So this was a positive study. However, then the KEVA study, which came out of Netherlands, it was published in 2020, and they actually did ultrasound accelerated catheter directed thrombolysis using the ECO system. And they use urokinase as the drug for thrombolysis, and compared with the standard therapy, there was no change in the risk of post-thrombotic syndrome at 1 year. So this was basically a negative study. Then the TRACK trial, which is a big trial published in NEJM, done here in the United States, in which 692 patients with acute proximal DVT randomized to anticoagulation alone or anticoagulation plus pharmacomechanical thrombolysis. The overall incidence was similar as were quality of life measures. What they did find that people who did undergo thrombolysis had moderate to severe post-thrombotic syndrome occurring in fewer patients than those compared to the control group. So no overall, it was like not a very robust pointing, robust indication for thrombolysis in every patient based on this study. Then we get to this ACCESS PTS study, which is again has been recently published. This is for patients who already have established post-thrombotic syndrome. This was done again as a multi-center, single-arm prospective study evaluating patients with chronic DVT and post-thrombotic syndrome. So they had, all of them had been treated with a minimum of 3 months of anticoagulation. The Villalta score was greater than equal to 8, putting it in the moderate to severe category. And these patients underwent randomization to include percutaneous transluminal venoplasty and then ultrasound accelerated thrombolysis with the ECO system. So it was an industry-sponsored trial, and data was collected on the clinical characteristics, the Villalta scores, imaging, and quality of life at 1 year. The primary efficacy outcome was a reduction of greater than equal to 4 points in the Villalta score 30 days after the procedure. The major safety outcomes that they looked at was bleeding within 72 hours and any symptomatic pulmonary embolism during the index hospitalization. So this was the hospital-based trial, and every patient would remain in the hospital for about 3 to 6 days. And this was the breakdown of the study. About 82 limbs were treated. Average age was 54.6. A third of them were women. And the mean Villalta score was 15.5, which was actually quite high. So most of them had severe post-thrombotic syndrome. And what they found was that primary endpoint was met in about 65% of the patients. And at 1 year, 77.3% of these limbs continued with a Villalta reduction of greater than equal to 4. And at 1 year, greater than 90% of the segments had patency with ultrasound flow present. And in addition, all the quality of life scores that he used had a statistically significant improvement in the patients who were treated with the ultrasound guided thrombolysis compared to people who did not undergo that. Iliofemoral venous stenting was performed in 42 patients in this study, with similar improvements seen in all outcomes regardless of the stenting status. And the only mortality was one patient who had severe bleeding, actually presented with epistaxis, then went into shock and eventually died of septic shock at 32 days after the procedure. So mortality was 1.3%. They did not report any patients undergoing a pulmonary embolism or during this process. So in conclusion for this study, percutaneous transluminal venoplasty and ultrasound accelerated thrombolysis resulted in successful recanalization of chronic venous obstruction with improved post-thrombotic syndrome severity and quality of life. And these results were sustained at 1 year after procedure. So this was a positive study for patients who have established PTS. So this takes us to the treatment part of post-traumatic syndrome. Exercise is recommended for all these patients because flexing the ankle and walking is improving your calf muscle strength, which is the calf pump, which helps to then augment the drainage of the blood out of the leg and improves the drainage and it lowers the venous hypertension. Also, elevation of the extremity when at rest achieves the same results. Pharmacological therapy there's not much to go there. Essen, which is a horse chestnut seed extract, has been tried and may be beneficial in some patients. Vasculera, which is now it's a FDA-approved medicine, which is a diosmiplex purified flavonoid compound, which prevents inflammatory damage to the vein wall. It is now available, for patients who have this PTS syndrome and who've not really improved with exercise or compression. So this is an alternative that is available now to us. It does cost a lot of money though. Epiceram, which is another cream or an emulsion, which contains ceramides, cholesterol, and free fatty acids, helps to repair and heal the skin barrier. It has been shown to improve the skin hyperpigmentation and the overall health of the skin in patients who have skin changes secondary to PTS. Compression-based therapies, as far as the prevention is concerned, there is conflicting data again. The SOX trial, which was published in 2014, was a negative trial. They did not find any evidence of prevention of PTS after first proximal DVT. And then there was another trial, which was an ideal DVT trial, in which they did a sub-analysis and found that patients who received compression therapy immediately after DVT had a significantly lower percentage of residual vein obstruction. Now, whether that translated into symptom relief was not really mentioned there. However, once the diagnosis has been made, then compression therapy becomes the cornerstone of managing symptoms and the sequelae of chronic venous disease. And commonly used forms of compression stockings include the short straight bandages, zinc-based bandages, and multi-layer compression. And there's also a benefit of using the intermittent pneumatic compression, which is the lymphedema pump, and that may offer symptomatic relief for patients with moderate to severe post-thrombotic syndrome. And of course, if the patient has an open wound and open ulcer, then moisturizers are recommended, and sometimes a mid-potency topical corticosteroid, and the patient will always benefit from aggressive wound care at a wound care center, in addition to treating their underlying venous insufficiency. So moving on to venous interventions, which is something very close to my heart. So the recommendation always is that if there is a patient who has a PTS, you should always look for any iliac or iliofemoral outflow obstruction, and those should be addressed if possible. The rationale behind that is if the patient has had tibial or infrapopliteal DVT and is having symptoms from that, right now, unfortunately, there's nothing really to be done for that. But however, if the patient does have associated outflow obstruction, meaning the iliac veins or the common femoral vein is narrowed and compressed, if you restore the outflow by opening that up, that will at least help the drainage out of the leg to whichever is reaching up to the groin area is now able to flow out better. So that reduces the venous hypertension and improves the symptoms in turn. So this is a case of a 68-year-old female. She had a left leg DVT ×2. Many years ago, she had the classic post-traumatic changes in her left leg, evaluated at Center for Vein Restoration first, was not found to have too much stuff going on in the superficial veins, and sent to us for evaluation of a deep system. And this is a venogram. On the left side is the pre-intervention venogram. You can see this is basically the common femoral vein where the sheath is entering, the external iliac vein, the common iliac vein on the left, and this is on the right. And you can see the difference here. There is significant narrowing and scarring inside the vein. There is a lot of crossover collaterals because the blood is not able to drain out completely from this area. And there's also an ascending lumbar collateral, which is trying to fill up to try to get the blood out of this area, which is the one which is the most compressed or most stenotic. And after we put in 2 overlapping stents, we were able to restore the iliofemoral drainage, and which in turn then helped with patient symptoms significantly. And this is just an intravascular ultrasound, the same patient. This is the IVUS probe. We park it all the way up into the inferior vena cava. She does have some IVC compression too going on here. And then we slowly pull it back and take a running pullback images. This is where it gets compressed really, and you see all this white area is inside is the post-thrombotic changes from the scarring and the webbing, which is going on inside this vein. And once we have identified that, and she got the stent, this is the intravascular ultrasound after the stent was put in. So, right here is the IVC, and this white outline is the stent now. So it's propping the vein open, scaffolding it, improving the outflow and drainage, and which in turn then relieves the patient's venous hypertension and takes care of her symptoms. This is another patient, 48-year-old female, who presented to us with pelvic pain and severe leg pain. And this patient denied any history of a DVT, interestingly. So she was seen at Center for Vein Restoration, then sent over to us, given her pelvic symptoms. And we did and her transabdominal ultrasound did not really suggest, was not really suggesting that she has a complete occlusion. They said that the weight was, the report was mentioned, or there's some narrowing going on, but they were not sure whether it's completely obstructed or not. So given her symptoms and signs, we put her on the table. She underwent a venogram, again, on the right side. This is on the left side, and you can see this left hypogastric is significantly dilated with all these cross-pelvic collaterals happening. There's a very tiny flow going up here. This could be the native channel, which is completely occluded, the native iliac vein. And then you can also see the ascending lumbar collateral here, which is, again, these are very pathognomic features of patients who have this complete occlusion of their iliac vein. And this patient underwent one long stent. It was a 16 by 140 Venous stent with complete restoration of loop and improved flow out of the leg, and subsequently her symptoms improved quite significantly. And this was her IVUS. This is the pre-procedure on the left, the post-procedure on the right. So parked it all the way up into the inferior vena cava. We're slowly pulling it down, taking a pullback run, and you can see where it starts to get compressed right about coming up here. That's the right common iliac artery coming across, completely gets occluded here. And still see a lot of occluded vein, completely occluded vein, and then becomes the external iliac starts to narrow down there again. And then this is the one which is the post-procedure with the stent in. That white outline is the patient's stent. And we got very good results with the stenting on this patient too. I think that was the end of my, so this is our Vision 2021, which is going to be a virtual meeting coming up on January 31st, 2021, which Center for Vein Restoration runs for updating physicians and providers for the latest in venous disease.
So Gaurav, thank you very much. Thank you for an absolutely amazing, very concise. You stayed to the 30-minute timeline so that we can get a lot of questions, and we do have some questions coming up. But while we have them, let me ask you, so you've touched on everything, but for somebody sitting in the clinic, they see a patient, say 3 months after iliofemoral DVT, come in with a swollen leg. How would you like them to proceed? And I specifically ask that with respect to anticoagulation, with respect to compression, and any other medications that you very nicely mentioned. So scenario one is the 6 months that you mentioned haven't passed, 3 months, unilateral iliofemoral DVT, which was diagnosed, and now the patient has unilateral leg swelling and everything else that looks like post-thrombotic leg.
So, as far as the anticoagulation is concerned, that we have to allude to the chest guidelines. If it's a first unprovoked DVT, you treat it for 3 months, depends upon patient's risk factors. If it's an obese patient, immobile, you may extend it to 6 months. If it's a recurrent DVT, then it's probably subjecting them to lifelong anticoagulation. Of course, you need to get thrombophilia testing for that. So that the anticoagulation has to be addressed in that manner. As far as the patient's symptoms is concerned, you definitely want to start them on compression therapy, compression stockings if they are not already on it. And they should have a evaluation by a venous expert. I mean, you start with Center for Vein Restoration or, for the superficial veins, and then also we have to make sure that the deep system gets evaluated. And it all depends upon the patient's presentation. If there is a lot of significant symptoms in the form of pain in the leg, which is not getting better with the conventional treatment or conventional, meaning compression therapy, leg elevation, then there is always room for us to do a intravascular ultrasound through the venogram and then address it by if there is significant compression that we can cross through and open up with the stent, we can offer the patient that option.
So essentially, again, just to summarize what you said, what you're saying is whether you give them anticoagulation or not depends on overall the chest guidelines. And with respect to compression, would you start them on a lower compression just to make sure that the patient tolerates that with the swelling and then gradually increase the compression?
That's the biggest issue that has been we have with trying to get the patients to be compliant with compression therapy. So the recommendation normally is 20 to 30, and then you go up to 30 to 40 if they're not. But if it's a morbidly obese patient, older patient, joint issues, you may want to try compression wraps, maybe try 15 to 20. Nowadays, we have the aids available by these companies. They help to basically put on the stocking with much less effort. So in my theory, in my practice, I tell the patient, zero is, anything is better than zero. So even if you can get a 15 to 20 on and you're able to tolerate it and get used to it, I would start with 15 to 20 and then gradually progress. Once the patient's swelling starts to get down, they're able to get a little better, hold on and get used to the way the compressions are applied. Then you go up to 20 to 30. And then if they can tolerate absolutely, then 30 to 40 is probably the best for, especially when it's a big post-thrombotic leg.
Okay, so let's go to the next step now. The referring patient, the referring physician, a physician who trusts Center for Vein Restoration has sent this patient to Center for Vein Restoration, and the ultrasound now shows that there is subtotal occlusion of the common femoral vein, subtotal occlusion of the common iliac vein, external iliac vein. All the infrainguinal veins are open, and there is a lot of reflux they see in the great saphenous vein, and the great saphenous vein size is also, let's make a number up, 8 millimeter, 9 millimeter. In that case, would you recommend that our partners over on the superficial vein side, they go ahead and treat the GSD, or they refrain from treating it? What is your thought process there?
See, it's a tricky question. Again, it also depends upon the comfort level of the patients who are of the physician who's treating this patient at the Center for Vein. Most of the times when you have a post-thrombotic occlusion, there is very good collateral circulation which is set up, which is essentially trying to get as much of that trapped blood out. So in theory, even if you ablate the GSV, which some say is the patient's collateral for helping to get rid of or get the drainage out when you have a post-thrombotic deep vein, which is completely occluded, that we should not touch that. We should not close it, or we should not address it right away. But I think if you have to do it, you can. I don't think there's any fear of worsening of the patient's symptoms. Some patients may have worsening after you ablate their superficial veins, but I think there is very robust collateral flow, which is getting out of the leg, and it should not be an issue. Now, if the patient's symptoms do improve after you do the ablation and they're doing fine and the leg swelling gets better and the heaviness and the achiness and the pain improves, then you just keep an eye on it and keep using the compressions. But if the symptoms are partially improved or not improved at all, then the option is to try to open up the occluded iliofemoral venous system.
Yeah, I'll tell you the way I approach that is, if it's SEEP2 disease, then I would want to do the minimum possible. And if just treating the superficial vein takes care of the SEEP2 disease and as you said, the signs and symptoms associated with that, and we can avoid putting a stent in that patient, that's what we would do. But usually, just like you pointed out, if it's SEEP4B or higher, those patients really would not respond only through treatment of the superficial vein, and then treating the superficial vein in that case in somebody with a known documented DVT may not just do it, and those patients should be sent to a deep vein expert sooner than later. Okay, now let's take the same question and say that the patient has come to the referring provider, to the primary care provider, a year after their known DVT. Does anything change? Does the therapy still remain the same?
I think, yes, the therapy still remains the same. You always try conservative measures first, and they failed conservative measures, then you start looking for, ways. The minimal invasive treatment first, of course, is the reflux and the superficial venous insufficiency. You treat that. If there is an ulcer, you look for perforators. I know you guys are the experts for that. Because if you look at Access PTS study, their follow-up or the patient cohort which was included, there was only the minimum time from DVT should be greater than 6 months, but there was no maximum time. The patient could be having post-thrombotic syndrome from a DVT which happened 5 years ago, and those were included in the study. So the outcomes are always going to be better if you base your if you base your thinking on this study. So no matter how long the symptoms have been or how long the DVT was, your success rate for the intervention may go down because of the chronicity of the disease that you are tackling now. But the symptoms will improve, because the first patient that I presented, the first DVT was in 2002, so 18 years ago. And then the subsequent DVT was, I think, 2011 or 12. But, again, that should not be something that would hold you back, that this patient had a DVT 1 year ago, and we don't know if this is going to get better or not. You always have to try, especially if the patient's symptoms are lifestyle altering. So
thank you. We're going to take some questions, Gaurav, now that have come through. The first one, I'll take a very easy one, which is that Dr. Sundaram is asking if it is possible to have a copy of the slides. Yes, sir. All these slides go on our website. In fact, for those of you who are new to the Venous Exchange program, all of our previous programs with their slides, with a complete recording, are on our website. And I think the slides are in a downloadable format. If not, just send us an email and we'd be happy to share these slides with you. Dr. Don Ives, Gaurav asks a question: when the superficial lower extremity ultrasound is performed prior to the ultrasound, were there any significant findings, such as changes in the physicity of the deep system, or do you perform IVUS based on clinical findings alone?
No, we always look at what the deep ultrasound shows as the pelvic ultrasound, as we say. The first step always is to do a pelvic ultrasound, and we try to look for any changes in, is it not phasic anymore? And we always try to visualize the vein in a sagittal view and a two-dimensional view to see if we are able to actually see flow inside the vein or not, and do measurements. If we can find measurements, we can find areas where we can measure, we do that. And then next step is, of course, doing the IVUS. Now, if the patient's symptoms and signs are very, very suggestive and very compelling, and the ultrasound is inconclusive, we get a lot of patients who are morbidly obese, the body habit is as such, you can't really visualize what's going on. then of course, if it's clinically indicated, we'll proceed to the venogram with the IVUS. But the first step always is to do a pelvic ultrasound.
And Don, just like what Gaurav said, the first step is always pelvic ultrasound. But if the patient clearly has symptoms and signs of what you think is deep venous disease, the only definitive test that'll prove or disprove this is an IVUS. Venogram gives you a good indication, but it's just an indication. And as a practice, our threshold to get an IVUS done in somebody who has the right symptoms and signs is really, really low. We would not be doing our patients justice if we do not do an IVUS in somebody with the right signs or symptoms. Gaurav, next question here is from Dr. Hollenbach. Are you more a fan of blood thinners for treatment of DVT over any of the new procedures to remove the clot?
Again, a very interesting question. So, if you are able to catch it, and so it all depends upon the location of the clot. If it's in the iliofemoral area, meaning it's the big vein up above the inguinal ligament, or it extends into the femoral vein, and it's a much extensive clot. Some people will present with clot extending from POP all the way down into the iliac. I think, and you catch it within 21 days, if the patient gets diagnosed within 21 days, I think they will benefit definitely from a more aggressive pharmacomechanical thrombolysis or clot, thrombectomy, as far as the long-term sequelae, meaning post-thrombotic syndrome and the resolution of the symptoms is concerned. If it is a infrapopliteal DVT in the tibial vessels, I'm absolutely okay with just treating them with conventional anticoagulation. But if it's a very acute, what we call phlegmasia kind of appearance of the leg, then those benefit from aggressive thrombolysis, whether it's CDT or pharmacomechanical, or just doing embolectomy or thrombectomy. So it goes by the patient's clinical presentation, and especially if you get it within 3 weeks. I think there was a lot of studies which came out before ATTRACT in which they had, and they were, however, not randomized. They were just retrospective analysis in which people who had active clot removal did better. But ATTRACT was a randomized trial which kind of disproved that. But I think you just have to take it on case-by-case basis.
That's great. So next question is something you got to put a lot of your brain cells to use here, Gaurav. This is from Dr. Tran. How would you treat a patient that came in with a markedly swollen left lower extremity? Ultrasound revealed an occluded common femoral vein. It's both mixed chronic and acute thrombus. There is a DVT, again, acute and chronic in the popliteal, non-occlusive. Collateral flow via epigastric vein and the GSV. Patient states they have been living with this for 2 years, and other than the swelling, they feel they are asymptomatic, seemingly unprovoked, coags negative for thrombophilia, placed on Eliquis with no improvement. So I'm assuming the improvement that Dr. Tran is looking for is purely in the swelling, because otherwise the patient is asymptomatic, and no improvement with Eliquis a month later.
This was the Eliquis was put in at the time of the presentation of the patient to the physician, or was it? So we don't know the chronicity of this disease. Yeah, you say acute on chronic, they said, right? So yeah, it's an interesting clinical scenario. Personally, I would tell you what I would do. I would try to maximize conservative management for this patient, especially if it's swelling is the only thing. Try compression therapy, try intermittent pneumatic compression, lymphedema pump. As long as there is no loss of skin integrity, meaning an open venous ulcer, or it's really, really friable skin, or multiple recurrent cellulitis episodes because of the compromised skin, I would err on the more conservative side here. Now, if the patient has an open venous ulcer, or it's multiple infections, or it's really, really, really painful and swollen leg, then you could try approaching the tibial veins. In the access PTS, they did go from majority of the patients, they had access the popliteal veins, but they did go into the tibial veins too. So you could try to go through the tibial veins and see if you could try to recanalize the occluded pop and then the common femoral. Our experience has been that, post-thrombotic limbs or post-thrombotic veins which are open up with stent have a very high likelihood of closing up. The patency rates are not that great. The cumulative patency, meaning if you look at the primary, secondary, and assisted, that may get better, but again, it has to be recurrent procedures being done on these patients to try to keep the stent open. So if we think that this is something which can be managed conservatively, you could try the Vascular, you could try the SN, and see if that helps. I would go the conservative route first.
Yeah, and I would agree with you, Gaurav, especially when the patient feels that they're asymptomatic. And swelling, as we all know, is probably the hardest thing to treat in these patients.
Yep.
So, okay. Well, let's go to Dr. Levine's question. Are over-the-counter compression socks as good as custom-made?
Yeah, actually, that's a very good question, because when a patient presents to me, we will tell them that they can go to Amazon and get the 20 to 30 compressions from Amazon, and it goes by the foot size. And as long as it's somebody who does not need special fitting, meaning that they have very huge calves and huge ankles or a body habitus which is morbid, they over the counter work pretty fine. We've had very good, and they're very cheap. They're very affordable, because some of the prescription ones can cost patients hundreds of dollars for one pair of stocking, whereas Amazon gives you 5 pairs for $30. So I've had no
even
problems.
A better pair of compression stockings, Gaurav, you can get from cvrcompression.com.
Oh yeah, there you go. You have another alternative now, which is, I think, probably the best.
As people are of normal size, all that works out really well. Great. And then we have from Amy, we have a question. Prior to implementing compression therapy, do you typically screen for arterial disease via ABI, TBI, or PVR?
Not really, not unless you have the patient has has a lot of risk factors, and you suggest that there is probably underlying significant arterial disease. I think the absolute ABIs of less than 0.6 is a contraindication, and I think if on top of my mind, I think I'm missing the number. I think it's less than 60 millimeters of mercury or less than 80 millimeters of mercury absolute ankle pressures is a contraindication, but otherwise you can start them on the compressions without checking for ABI or TBI in every patient.
Yeah, and also, Amy, again, if you start doing this in every patient, then Medicare does not appreciate that either. So unless you have specific reason to challenge that the patient needs compression stockings yet has bad arterial disease, that's where it'll be okay. We actually, since we prescribe a lot of compression stockings, we looked at that point with our compliance people, and the general belief was that we should not be testing them just for that as an indication. So Gaurav, the next question here is from Dr. Reese. Anything new from the standpoint of femoropopliteal level deep venous valvular repair / replacement as opposed to iliofemoral veinoplasty stenting to eliminate post-phlebotic symptoms? So essentially, anything new about the valve replacement stuff that
there have been a lot of valves in the pipeline, I know, and some people try to use it, but the success rates is not that great. So there's a lot of failure rates. It's a very morbid procedure. They haven't perfected the endovascular implantation of these valves. I know there's a bunch in the pipeline, but there haven't been any what we call head-to-head studies and outcomes that will stand out giving this as an option for now.
So guys, also, if we just look at it, this is a low flow system, right? The venous system is a low flow system, low pressure, low flow, and trying to keep valves open. I know it sounds really sexy that we're going to have venous valves in place in another year or 2 years. That's going to be a very, very hard thing to accomplish, because first of all, wherever you put stitches, wherever you break the intima there, that is going to be a thrombogenic site. Secondly, unlike in the arterial system, here it's a very low flow system. So I agree with Gaurav. It's going to be a while before we get anything. Probably Elon Musk is the only one who can come up with something that'll work here. It's and something that's scalable, something that a lot of the physicians can really put into practice. So we don't have anything so far, and doubt anything will really come at that scale anytime in the near future. So Gaurav, while we wait for some more questions, tell us a little bit about infrainguinal um, venous repair. So if you have subtotal occlusion and like the question that was asked on the popliteal side, or maybe it's in the femoral vein, what is you kind of touched on it, but if you could go a little bit more into the details, how all would you treat, or if at all you would treat subtotal occlusions or chronic occlusions below the inguinal ligament in the venous system?
So again, it's a very controversial as far as the outcomes is concerned. I know, again, I keep alluding to Access PTS because that's the only good study that we've had so far. They did intervene on these. So the way the procedures were done, they would do if they were able to recanalize a occluded femoral vein, they would basically venoplasty it first with a 8 to 10 millimeter balloon, and then they would drip the TPA with the help of that accelerated thrombolysis with the ultrasound catheter, the ECO system, and drip it for 12 hours, and then have the patient come back and basically take another venogram, and then if needed, replasty it. So, and then that's the way they did this, the study. If you are doing this just by doing a venoplasty, meaning you are able to cannulate, recanalize the occluded vein, and you put a balloon and you just stretch it out and take the balloon out, those veins will not stay open. There is a very, very high likelihood of restenosis or rethrombosis of these femoral veins if treated with plasty alone. And I'm talking this out of personal experience. Now, if there is a way in which the patient can be, sent to a hospital-based setting where they can be treated with this TPA and the ecosystem and doing the venoplasty at that point, the chances are that they may remain open is much higher based upon what the Access PTS tells us. There is no role for stenting in the below the inguinal ligament. They used to do that in the past, and these stents invariably close up, and that causes more damage than more symptoms. Instead of giving any benefit to the patient. So I tend to leave the occluded femoral veins alone. I would try to look at the outflow at the iliofemoral, meaning above the inguinal ligament coming up to the common femoral, because if that is stenotic, then maybe treating that or addressing that may be a better option than just trying to balloon the femoral veins, which are not going to stay open. I mean, by plasty alone, it's very, very, very low rates of patency when you do plasty alone in the femoral veins.
Tell us a little bit about the exercise. You mentioned post-thrombotic leg syndrome is helped with an exercise regimen. How, something as simple as that, obviously it's very, very helpful, but how much do you tell your patients to walk? Any specific exercises you recommend?
So, walking, I mean, is good for your overall cardiovascular health, I would say. So, I mean, I tell the patients if they can do 30 to 45 minutes, 6 to 7 days a week of walking for the sake of walking, not just what they do around the house or at work, I don't think there is any guidelines per se as to what the amount of exercise should be, but anything which basically pumps your calf muscle is what you're trying to invigorate, so that the drainage or the what you call the emptying of the veins from the calf can happen, so that reduces the venous hypertension. It's the basics of venous disease. So you are basically trying to reestablish the calf muscle to get working the way it's supposed to, so that whatever is, even if there is a lot of occlusion and there is a lot of blockages up in the femoral vein or the popliteal vein, there is a good robust system of collaterals, and that needs to drain out. So once you build up your calf muscle strength and you do that on a regular basis, you're reestablishing the calf pump, and that helps to lower the venous hypertension by establishing or reestablishing or increasing the drainage out of the leg. So, but there's no particular number that I tell, but my standard is 30 to 45 minutes, 6 to 7 days a week. That's for all arterial patients, and the same thing I tell for all the venous patients, and this based on the ACC guidelines for patients who have peripheral arterial disease, that you should recommend that.
Any role of aspirin or Plavix or any other antiplatelet therapy? So let's assume you finished the 6 months on a non-provoked or in a, and you followed the guidelines, and now the patient is not on any anticoagulation, but the patient clearly has post-thrombotic leg. Would you keep the patient on any kind of antiplatelet therapy at all, or any anticoagulation therapy?
So again, if this is just a single episode of an isolated DVT and you've followed the guidelines and treated them the way they needed to be treated for 3 or 6 months, I would not really be, I'm not too keen on continuing anticoagulation. Now, if it's a recurrent DVT and if it's something else, if it's a high-risk patient, then we can, think about individualizing the treatment. But aspirin 81 will confer about a 25% risk reduction for recurrent DVTs, and that's been shown. If you go to the DOAC therapy, then the benefit goes up to 80-90%. So if the patient is a candidate for the direct oral anticoagulants, then definitely continue with that. If they have thrombophilia issues underlying, we always get hematology involved and get their recommendations too as to whether this patient is going to benefit from any long-term anticoagulation versus just the 3 to 6 months. And
but just for the improvement of the leg symptoms, you don't feel there is any indication?
No, I think for that the compressions work the best. Compression therapy works the best for both patients with established PTS.
Great. Hey, Gaurav, thank you very much for an absolutely amazing talk and covering the topic so well. As you pointed out in your first few slides, that this is not as rare a condition as we might think. Like you said, 20 to 50% of patients who get a DVT, which is about 1 million people a year, will end up with, and that's the people we know, right? And then there's so many people who get DVTs that we don't even know. And this is a very, very major epidemiological issue. And thank you for, educating us on this. This is great. And guys, as we are coming to closing our hour, I really do want to request you guys to join our Vision 2021. It's on January 31st. We really have an absolutely amazing lineup of speakers. It is completely free. It'll give you 5 hours of CME. And we've got our Chief Medical Officer, Ken Wen, Dr. Pappas. We've got Dr. G. Lakhanpal again is talking. Dr. Satwa is talking. We've got some amazing outside speakers like Dr. Mark Meisner. So it's going to be really, really worth your while. And we sure hope you will join us. Thank you again, Gaurav.
No, thank you.